Chinyere Ugorji, a 2007 graduate of American International School of Medicine with 10 years of clinical experience working as a certified nurse aide at various hospitals, long-term acute care facilities with patients in their private homes, from doing my clinical rotations here in the United States, from 2 graduate medical education programs, Henry Ford Internal Medicine Residency Program, Detroit, Michigan, Springfield Family Medicine Residency Program, Springfield, Illinois, from various observerships and externships, and from my various preventive health fairs where I've had the opportunity to have hands-on experience, and with a master's in business administration with an emphasis on public administration from Davenport University, Grand Rapids, Michigan, and research experience from UT Southwestern Psychiatry Department, working with Dr. Carol North and Dana Downs, who are both awesome people, and currently involved in education and preventive health fair, and preventive health care, utilizing my Ustream channel and my YouTube channel, and also applying for residency this year. I want to welcome you all to Dr. Chiquito Mentoring Ustream Show, where we are always learning about a health topic every day. I want to thank everybody who has taken the time to log into the shows, to watch the videos. We've had lots of interesting topics in the past, and this week we have lots of interesting topics, and also this show is also designed to be able to help those who are interviewing for residency with the residency interview process, which is a very exciting time in your life. It's a new step in your career. And we actually talk about a residency interview question every day, something that you are gonna be asked when you go for your interviews, and suggested answers. And with that, you can feel equipped, you can feel good to be able to go for your residency interviews. Yesterday we talked about croup. And yeah, we had a Powerball question. Is croup more common in boys than in girls? We talked about that, and if you read the article, if you watch the video, if you watch the Ustream broadcast, you can be able to answer that question. So today we're talking about bronchiolitis, about bronchiolitis, and also the residency interview question of the day is when was the first time you knew what you wanted to do, what specialty you wanted to do in your life? And we will have an answer to that, towards the end of the show. The show today is starting by 10:30. I apologize for the discrepancies in time. We are gonna be having Wednesday shows by 10:30 a.m. because I have some other engagements to do, and also it's gonna just be a short show. It's gonna be from 10:30 to 11 o'clock because of the University of Texas Southwestern Psychiatry conference, which I try to attend. I'm not a resident there, but if you call them, if you talk to the program coordinator, they are willing to let you attend it, once you go through the proper protocol. They have a very strong program, and I would recommend it to anyone. So today, today we are talking about bronchiolitis, and on Thursday we'll talk about dysfunctional uterine bleeding. On Friday we'll talk about septic arthritis. Then on Saturday we'll talk about Zumba dancing. We'll do Zumba dancing by 12 o'clock. It's something I picked up as a hobby, a very rich part of the Latin culture, and I would like to help us learn this hobby of Zumba dancing. And then also we are also going to talk about lots of residence interview questions. Tomorrow we'll talk about where do you see yourself in 5 to 10 years. And then on Friday we'll talk about, do you have any criminal records? And all these are questions that you are going to be asked on as you go on the residency interview trail. So I would encourage us to log in and also share your interview experiences. It's an awesome time that you actually get to meet lots of residents, lots of coordinators, lots of people. You get to explore various cities in the United States. You get to move, decide where you want to spend the next 3 years of your life, the next step of your career. So I would want us to be interactive and post on my social stream, on my Facebook wall during the show and also after the show. So today I have a case study that is designed to be able to help us to understand the topic bronchiolitis. I actually talked about I've talked to a few people about bronchiolitis during the week. I talked to a healthcare professional and I asked her, "Do you know what bronchiolitis is?" And she said, "No, but I would like to know." So I gave her the information to be able to watch the show and watch the video. And I also talked to another gentleman who also did not know what it was too. So if you're out there, well, I hope you're watching the video. I hope you're watching the show, and feel free to ask your questions. So this is a case in the outpatient clinic. Vital signs: temperature is 37.8, pulse is 145, respiratory rate is 33, blood pressure is 88/52. And the patient is a 3-month-old infant who is brought to the clinic by his mother because of a 2 to 3 day history of runny nose with congestion, low-grade fever, and poor eating. He also vomited several times, and the emesis is usually mucus mixed with some of his feeds. He's more irritable and has difficulty feeding, but appears to be still taking in his usual amount of formula. Mother reports, however, instead of feeding the formula over 15 minutes, it's taking the baby 35 to 40 minutes to finish his usual bottle of formula. The patient's temperature has been a maximum of 100.6. He has 2 older school-age siblings who had upper respiratory infections during the past week. Mother is concerned because the baby's breathing is much more noisy. Review of system: somewhat increased irritability, but consolable. Urine output is normal, no diarrhea, no constipation, vomiting as noted above, no episodes of cyanosis or apnea, episodes or rashes. Past medical history: the patient was born via normal spontaneous vaginal delivery. He was circumcised and had no bleeding diastasis. He went home with his mother after 48-hour hospital stay. He has had 2-month immunizations, including DTaP, HIV, second hepatitis B, pneumococcal conjugate vaccine, and IPV. Development: he has been meeting his milestones. His eyes track to 180 degrees bilaterally. He moves all of his arms and legs well. He does not yet roll over. He has a fair degree of head control. He has a social smile and interacts well with his family. Social history: he lives with his parents and 2 older siblings. They have 2 cats in the house. They have well water. The patient does not attend any daycare. There is no smoking in the home. Family history is positive for allergic rhinitis and is otherwise negative. Mother was group B streptococcal infection positive and received prophylactic antibiotics intrapartum. So this patient has a runny nose with congestion. He has a fever. He has vomiting. He also has he's also lethargic, and also he's not feeling very well. So with all these symptoms, I'm pretty sure you're thinking of something, of some differentials at the top of your head. You're thinking lots of things could actually be wrong with this little fella, this baby. Well, I mean, it could be aspiration pneumonia. It could be altitude related disorders. It could be croup, like we talked about yesterday. It could be viral pneumonia. It could be bacterial pneumonia. It could be chlamydial pneumonia. It could also be influenza. It could also be be um, be um, be be lots of other differentials too, which we'll talk about later on in the show. And but hopefully at the end of the show we can be able to determine why it's bronchiolitis and not any of those other differentials. So bronchiolitis, that's the topic for today, and I'm going to be talking from an article that is on my website, and I want to encourage you to check it out. And we'll talk about what bronchiolitis is. We'll talk about how common it is. We'll talk about the risk factors. We'll talk about the signs and symptoms. We'll talk about the differential diagnosis. We'll talk about diagnosis in terms of laboratory orders and imaging, and then also talk about the treatment in terms of medication, and also in terms of procedures. And also we talk about prevention, which is a very important part of what I do, and also of medicine. Preventive care is being emphasized. And with that, we'll go to the Powerball question and be able to determine exactly what bronchiolitis is. So what is bronchiolitis? Well, it's a viral infection, and it's an acute inflammatory injury of the bronchioles that is caused by a viral infection. And it's most commonly caused by respiratory syncytial virus and may occur in persons of any age with severe symptoms, usually evident only in young infants. And that's from an article written by Denicola 2013. How common is bronchiolitis? Well, it's actually found in 25% of children who are less than 1 year, 12 months, and 13% of children aged 1 to 2 years. And of this 25%, one have wheezing associated respiratory distress. That's from the Nicola 2013. So what causes it? Well, respiratory syncytial virus, that's the most common cause. Also, influenza virus also causes it too. Also, adenovirus too can also cause it. And something called metapneumovirus also causes it too. And paramyxovirus too is another cause. Then what are the risk factors? Well, never having been breastfed is a major risk factor. Babies who are breastfed actually receive immune benefits from the mother. So if the baby is breastfed, then that actually gives them antibodies. And then also premature birth too, that's also a risk factor. Having an underlying heart or lung condition is also a risk factor. A depressed immune system is also a risk factor. Exposure to tobacco smoke is also a risk factor. Contact with multiple children. So if the child goes to daycare, then that's also a risk factor. Living in a crowded environment, that's a risk factor too. Then having siblings who attend school or childcare and bring home the infection is also a risk factor. Differential diagnosis, well, there are lots of differential diagnoses like we talked about. It could be viral pneumonia, it could be chlamydial pneumonia, it could be bacterial pneumonia, it could be altitude-related disorders, it could also be influenza, it could also be aspiration pneumonia, it could be croup, it could be cystic fibrosis, it could be heart failure, it could also be pediatric apnea, it could also be pediatric foreign body ingestion, pediatric sepsis, it could also be pertussis, it could also be pneumothorax. So clinical presentation, how do we diagnose this illness? Well, symptoms, cough is actually found in 98% of patients. Low-grade fever is found in 75%. Labored breathing is found in 73%. Wheezing is found in 65%. Rhinorrhea is also found in as a symptom. Coryza is also found as a symptom. Conjunctivitis. The patient could also have grunting, nasal flaring, intercostal retractions, tachypnea, dyspnea, hypoxia, and cyanosis and apnea. Then what are the signs? Well, when you listen to the patient's lungs, you could notice diffuse wheezing. You could also notice bronchi and also rales too. So those are the signs that you actually notice. Then in terms of diagnosis, what are the diagnostic tests? Well, blood cultures are used as a diagnostic test, and then also urine culture and urinalysis is also used as a diagnostic test, and RSV swabs or washings of the nasopharynx is also used as a diagnostic test. Blood cultures are actually done to exclude any infections. RSV swabs or washings actually has an efficacy, test sensitivity of 80 to 90% and test specificity of 90 to 99%. The urinalysis and urine cultures are used to check for urinary tract infections, and this is actually done in patients who have bronchiolitis severe enough to consider admission. And most times it's found that a UTI, a urinary tract infection, is present in 12% of RSV patients. In terms of imaging, well, chest radiology is actually indicated. And what do we see in chest radiology? Well, you notice hyper expansion, We notice peribronchial thickening and variable infiltrates of viral pneumonia. Um, in terms of medication, how do we treat it? Well, oxygen therapy is actually one of the treatment modalities. Albuterol, that's another one. Atrovent is also another one. And also nasal saline is also used. And it's and then oxygen too, to keep the oxygen saturation 90% or above. And then albuterol actually does not improve oxygenation in RSV and does not shorten hospital stay in RSV. Nebulized racemic epinephrine has variable efficacy and requires 2 to 4 hours of observation after administration due to transient effect with risk of rebound. Also, hypertonic saline nebulization is also used, using a nebulizer dose, 4 ml of 3% hypertonic saline, which may shorten hospital stay, but not effective in preventing hospitalization. It may not be as useful for emergency care. And then also systemic corticosteroids, the most common steroid used is dexamethasone. It does not decrease the severity of illness or shorten the disease course, unfortunately. Another medication used is montelukast, and that has led to improved post-RSV clinical symptoms in patients aged 30 to 36 months. And helium oxygen therapy too is also on a treatment. And then aerolized ribavirin is also used as a treatment, and use is limited to immunosuppressed children with severe disease and may be useful early at maximal viral load and has a variable efficacy. So how do we prevent this disease? Well, hand washing is one of the prevention modalities. Keeping your child away from smoke, avoiding contagious exposures. In terms of medications, how do we treat this disease? Well, ribavirin is also used as a treatment. We talked about that earlier. And the way it works is a nucleotide analog with in vitro activity against influenza A and influenza B, measles, and RSV. And it has a lot of possible benefits, which includes reduced time on ventilator, shortened length of hospital stay, and improves clinical scores. That's from an article written by Stina, 2004. Then RSV immune globulin also has been found to help. And then also medication called palivizumab, which is given monthly for up to 5 months of RSV season, which is what we are in right now, November 1 to March 1. In terms of procedure, well, suctioning of the secretions, that's one thing that can be done, and this actually helps to avoid trauma and secondary edema, and then also intubation if indicated. Prevention, well, promoting breastfeeding through the first year of life and avoiding exposure to secondhand smoke. And then also during the first 2 years of life, it's also advised to provide palivizumab to premature infants and infants with significant lung or heart disease. That's from an article by the American College of Physicians. And then coding and billing, ICD-9 is 466.1, ICD-10 is J21, comes right after CRO, which is J20. And so this patient actually has bronchiolitis, and that's the final diagnosis. I have a PowerPoint question that is designed to help us to read the article to be able to understand about bronchiolitis. And the PowerPoint question is blood culture to exclude any infections, RSV swabs or washings of nasopharynx, throat, or sputum is a test to diagnose bronchiolitis, true or false? So I want you to answer that question, and if you get the answer right, you can be able to get a shot at winning the prize from our various sponsors. I have lots of sponsors from various graduate medical education programs, and also various organizations, and with that, you can be able to get a shot at winning one of the prizes. The drawing will be done on Saturday by 12 p.m. when I'll be doing the Zumba dancing illustration, and with that we can be able to learn about what we've talked about, or we can be able to ensure that we have actually integrated that and gotten an understanding of these diseases, which are mostly what we actually find during this season. And I want to thank the authors of these articles, which are my references: American College of Physicians, Smart Medicine 2013, Stina R. from the American Academy of Family Physicians, Denicola N. That's from eMedicine, and Family Practice Notebook from Family Practice Notebook website. I want to thank all of them. They've been very helpful. The articles are very helpful, and I would advise everyone to read it, and because it will help to consolidate that information. So with that, we'll go into the next section of the show, which is the residency interview question of the day. And for today, it's when was the first time that you knew your specialty was what you wanted to do for the rest of your life? So this is a very important question that most programs are going to ask their candidates, because they want to ensure that the candidate actually has a concrete knowledge, is actually sure that the specialty that he or she is applying for or is interviewing for is actually what they actually want to do, because that will ensure that they succeed during their residency. It's an opportunity to be able to tell the program or the interviewer your reasons for choosing that specialty, whatever specialty may be: family medicine, internal medicine, psychiatry, surgery, and to convince them that you are actually going to be a right fit for that specialty and for that program. So an example of an answer to this question would be the first thing that I knew that I wanted to be in this specialty was when I did my clinical rotations in that specialty. Primary care for me is actually I have always been into, what my training prepares me for. And during my clinical rotations, during my family medicine rotation, my internal medicine rotations, my psychiatry rotation, I was able to get a glimpse into various clinical cases, including the common cases that we see every day: chronic obstructive pulmonary disease, congestive heart failure, hypertension, diabetes, and also the various psychiatric cases that we see: depression, mania, mood disorders. And that actually convinced me that primary care, which is internal medicine, family medicine, and psychiatry, is really what I actually want to do for the rest of my life. So and also because of the pathophysiology, which I just listed a few minutes ago, the practice opportunities, and also the patient population seen in this field. So I have these answers on my website. You can be able to check it out. And that's the residency interview question of the day. Our feature residency program for today is Carbondale Family Medicine Residency program, which is a very, very strong program. I actually have interviewed there before, and I will talk about them in a few minutes. So I'm actually working on a research project on curriculum review to see how the structure of various graduate medical education programs curriculum affects the residents' board scores, their performance during the 3 years of their career in residency program. And the SIU Family Medicine Residency Program, Carbondale, actually has a curriculum that is distributed throughout the 3-year program, and the residents are actually required to be ACLS certified or before they start residency or within 6 months of starting residency. They also have weekly office hours in one or more of the family medicine centers, and provide continuity of care to an assigned number of families. They also provide periodic teaching of physical exam skills to medical students. For the second-year residents, they're assigned to geriatric training that consists of following several nursing home patients monthly. They require 21 hours of lab training is available, which allows graduates to be directors of their labs. They have educational conferences, which include current publication review, nursing home rounds, family medicine board reviews, sleep deprivation, chat rounds, geriatric topics, resident fatigue and patient safety. They have journal club, they have mortality and morbidity, assigned core topics, Valiant group, EBM outpatients and inpatients. They have challenger models, which are actually designed to be able to help the residents to be able to to learn about the didactics of family medicine and to score high on their boards. They also have sports medicine topics too. They also have ethics training, EMR training, and practice management. So in first year, the curriculum is designed that the first year residents stay in the family medicine center for 2 half days per week, with 50 assigned families. And then emergency department, 1 block, family medicine service inpatient, 4 blocks, obstetrics, 2 blocks, pediatrics inpatient, 2 blocks, general surgery, 1 block, cardiology, 1 block, community medicine, 1 block. And then during the orientation, they spend 1 block in orientation. In second year, they spend 3.5 hours per week with 100 assigned families. So the number actually doubles, because then the second year residents are actually equipped. They are more experienced, more confident, and more competent to take on this large amount of patients. The OBGYN block, the family medicine service inpatient, that's 3 blocks, pediatrics outpatient, 2 blocks, ambulatory care and practice management, 1 block, general surgery and ophthalmology, 1 block, orthopedics and sports medicine, 2 blocks, and then also various electives. You can be able to choose whatever elective you want to do. Then geriatrics is also 1 block, family medicine, preceptorship and practice management is also 1 block. In third year, they spend 4 half days per week in family medicine clinic. They have 150 assigned families. They have ambulatory care and CQI, that's 2 blocks. They have dermatology and practice management, 1 block. GYN is 1 block. Emergency department is 1 block. Community medicine and geriatrics is 1 block. Family medicine service is 3 blocks. And then electives is 4 blocks. There are a wide variety of electives that you can be able to choose from, whatever is your interest, whatever you think that you might want to practice more when you eventually graduate from residency. And this include plastic surgery, anesthesiology, endocrinology, pathology, physiotherapy, sports medicine, radiology, nuclear medicine, health service, neurosurgery, maxillofacial and oral surgery, and other advanced medical and surgical subspecialties. And this is actually all geared to be able to get you where you want to be, to make sure that you get the wide array of training that you want, during your residency training. The size of the program, they have 16 residents, and application information, they actually accept applications through ERAS, and you can visit the ERAS website for more information about that. My residency interview experience was actually very good. I actually found lots of good things about the program. They have a lot of strengths about the program, and I think that anybody who actually wants to be able to be exposed to a good family medicine, primary care training would find this program a very, very good program. So I interviewed with Dr. Quincy Scott. He's the current program director, and then also interviewed with Dr. Sharon Smaga, and also talked to some of the other residents during dinner, during lunch, and also during the tour. And then also the interview questions that I was asked, they asked me, tell me about yourself. This is a very common question that most programs would ask you, and I have a sample answer to that on my website. And then also they also asked me, what are you looking for in a residency program? That's also a very, very common question that you'll be asked to ensure that you actually know what you want before you go into this important phase in your career. So the strengths of the program, well, they are a university community program with many academic and social opportunities. They also have the ability and the desire to train physicians who will feel comfortable practicing in a variety of settings. They have access to numerous rural communities, and that provides a patient population which is diverse in its economic, ethnic, and educational background. They have a sports medicine fellowship which is accredited. So, and then also they are also the first healthcare center in Southern Illinois to be certified as a patient-centered medical home. We'll talk about that as one of the interview questions. What is a patient-centered medical home? Is actually something that that the primary care has actually put in place to be able to ensure continuity of care and to ensure an ongoing relationship with a healthcare provider, not just on the patient's acute problems, but on the patient's overall health and also the patient's and also the health of the patient's family. So the program director is Dr. Quincy Scott. The program coordinator is Chris Law. She's a very awesome lady, and I want to say hi to her. If she eventually gets to watch this video, or if she's watching this show, and you can be able to contact them at their contact information on their webpage, through their mailing address, and also through their phone number. And with that, this actually gets us to the end of the show. And remember, we have that Powerball question that we have to answer. And I also want to talk about some of the other things that we do. At Dr. Chiquito mentoring preventive care practice, we offer free preventive care and counseling for victims of domestic abuse and sexual violence, which is something that is a passion of mine. And then also we also offer free education. That's for residents and other healthcare professionals, and also for patients too. We also are part of TAWOS, which is a smoking cessation campaign of the American Academy of Family Physicians. And I'm actually going to be going to 3 schools today. I'm contacting 3 schools today in the Dallas metropolitan area. The list is actually on my website. You can be able to check it out to see if they can be able to get the middle school students be able to get involved in that competition, which will be done next year at the national conference in July. And then also yeah, I'm also part of various charity works, the Light and Night Work from the Lukumi and Informa Foundation, and also the AIDS Work South Dallas. And then also I want to remind us about upcoming conferences in the healthcare field, which can also be found on my website. You can actually click on where it says print, and you can be able to print out a complete list. The AHRQ web conference on the use of the teamwork training program agencies and how John Hopkins implemented the program in the current healthcare is going to take place by 1 p.m. today. So if you're able to attend that, that's actually designed to help us to understand how John Hopkins have implemented the teamwork training program in current healthcare. So it's a very important conference that I would encourage us to attend. And also there's also the psychiatry grand rounds at UT Southwestern Psychiatry Department, which is actually very enlightening and very educative, with lots of didactic topics that are pertinent to current healthcare. So I would advise everyone to attend that if they can. And I also want to let us know that the webpage and the healthcare news on Facebook is going to be updated between 3 to 6 o'clock. So, and if you have any questions, feel free to contact the webmaster using the email address on the website, or contact me, and I can be able to answer those questions. If you want any of the documentation, the documents, I can be able to get that across to you. I want to thank everybody who has logged into this show. It's 11 o'clock right now, and and hopefully, with the Powerball question that we actually talked about, blood cultures, RSV, swab washings, and yeah, I'm pulling up the Powerball question right now. Your blood culture, RSV, swabs or washings of the nasopharynx, throat, or sputum is a test to diagnose bronchiolitis. True or false? I want you to take a shot at that Powerball question, and I'll get the answers in my email, and you can be able to get you get an opportunity to be able to win a Powerball prize. And with that, I want to thank you all for watching Dr. Chiquito Mentoring Ustream show, where we always learn about a preventive health topic and answering the common residency interview questions that we actually encounter as we go through our residency interviews. And I want to wish you a wonderful rest of your day.